The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. This month, talking to Josh Bonkowsky. It's been fascinating talking about neurology, talking about the frontiers in neurology. Welcome back, Josh.
Hi, Paul. Good to be here today.
So to keep taking time with us, would you like to mention your disclosures again?
Yes, my disclosures are I write content for Up to Date, and I do consulting with a company called Ionis, and I'm involved in clinical trials with Ionis.
Terrific. And part of the reason why we're talking right now is A, it's always a delight to talk to you, Josh. But B, you published a book last month, April 2026, Dancing Eyes, Dancing Feet. Fascinating book that we've alluded to several times, and thanks for writing it.
Thanks, Paul. It was both a lot of work, but also a labor of love. And hopefully it's interesting to some people with stories about Utah and primaries and kids in the hospital.
No, and it reads like a labor of love. It's interesting because I think we forget, because you read memoirs, William Osler and whatnot, and I think we get the sense that sometimes the interesting reflections on medicine happened a long time ago. And the interesting reflections on medicine are happening all the time because medicine changes all the time. And I think it's a gift when someone reflects personally on their experiences because I think it humanizes the history.
Yeah, that's an interesting way to think of it. It's almost like snapshots on a camera. And at the time when you're taking the pictures, it seems silly to take these pictures. But then when you look back at what those pictures were, you're like, oh, we were at a specific place and time and history and what we were doing in medicine. And it helps us understand where we were and also helps us understand where we're heading.
Yeah, and I'm a different person now, and here's why.
Yeah, and seeing that path, you think, gosh, it's hard to predict the future, but when you look back and see the path you've taken, you're like, well, maybe it's not as hard to understand where I'm headed.
Right. You introduced me to a word I didn't know before, sialism. You want to talk about sialism?
Yeah, stylism's a not common word, but I was looking
A lovely word, though.
it does capture well some of the issues we're facing. And I was looking for a word that was the definition of a person or organization that had certainty in the absence of actual knowledge or expertise about what they were talking about. And so I think that we live in an era where families and professionals like ourselves are buffeted by social media, by things on the internet, with people making pronouncements about diseases or vaccinations or medicines or therapies, but with no actual science or knowledge to back up those claims.
Yeah, definition of sialism, being convinced of something in the absence of actual expertise or knowledge. I read a book a couple of months ago. It was written by a woman who had been a senior executive at Facebook. It was a big deal, nonfiction book last year. And she says at one point that the mission of Facebook, and let's be honest, the mission of social media and of a lot of other impulses is to democratize the way that we get information, which may be great if you're looking for ideas about what to wear. But I think that if my car is broken, I'm not necessarily going to ask just any one of my neighbors, how should I fix my car? Or I think that if I'm building a home, I probably need some actual information about the structure of the home. A couple of months ago we have a book club section of this. We talked about the Dunning-Kruger effect, the tendency of somebody with less knowledge overestimating what they know about something. And it's really unfortunate that I think there are a lot of people who live in fear right now of good science because of bad information.
Yeah, and it's made our work harder. And we were in an era in the 1950s or 60s where there wasn't decision making given to parents and families. That was a mistake, I think, by the healthcare system. But instead, we've swung the pendulum to an era now where there's no valuing of expertise or knowledge or work that's made it actually harder, I think, for families to take care of their children. I mean, I went to high school, I went to college, I went to medical school, I went to residency, I went to fellowship. I've worked in a laboratory, I've tried to publish papers, and yet I find myself in these discussions with families. So I have years and years of work, and I still face uncertainty about making right decisions. And yet families doubt. Sometimes they feel that they're getting better information from something they've read on Google or Facebook, and kind of devaluing the hard work that experts try and bring to them as they make their decisions about what to do.
Well, you're talking to a guy who's old enough to remember when people were excited about preventing polio and when the measles vaccine came online, that families were thrilled. And I think it's unfortunate that we've lost that perspective.
Yeah, my own mother, I mean, she grew up in Pennsylvania, and she told me stories about how summer camps would get shut down because of a polio outbreak. And
Yeah.
people have lost that perspective that there's real cost to these diseases of what we're dealing with.
Yeah, you also, in one of the later chapters, describe seeing a patient with subacute sclerosing panencephalitis, something that I think we all hoped would go away completely. And as we are now in mid 2026 in Utah, leading the nation in measles cases, it's something that will happen again. And that's just unspeakably tragic.
Yeah, I was speaking with my colleague Andy Pavia in infectious disease literally yesterday about SSPE because there's a time lag from the measles infection to the risk for encephalitis and then again the risk for SSPE. And we're starting to enter that window now where we in the hospital and also, I guess, as clinicians out in the community, this will need to be on our differential consideration of a child with neurologic changes. And it's something that at the time, what seemed to me like great learning experiences as a resident, but with no basis for something I needed to really think about, suddenly it's back on the front burner for stuff we'll be paying attention to.
Yeah. And in the case of SSPE, it can be a time bomb that's set for decades, and that just strikes me as so tragic. Anyway, let's move ahead. We want to talk about gene therapy today. So help me understand what gene therapy means.
So gene therapy is a big umbrella of treatment. And I guess in my mind, the simplest way to think about gene therapy is that it's any treatment that's designed to treat a genetic disease. So I think I prefer that definition because there's many different kinds of gene therapy, ranging from giving back the missing gene to trying to block a bad version of the gene. So there's lots of flavors of gene therapy. But the underlying thought is that you're giving a treatment that should hopefully correct or cure a disease that's genetic.
Give me a for instance of a particular disease and how has this applied practically?
I think the poster child for pediatrics for gene therapy is SMA or spinal muscular atrophy. And so I think many of us who have been in practice for more than 5 years remember seeing kids with SMA in the pediatric ICU during respiratory season and often passing away because in SMA, it's a genetic disease where the nerve cells that control breathing stop working and it gets progressively worse, and often kids die in the first 2 to 4 years of life. And so terrible disease, fairly common, about 3 to 5 cases every year in Utah, and just a bad disease, progressive with progression to death. 5 years ago, the first gene therapy for SMA became available. It was a treatment that had to be given every 3 months, had to be given by intrathecal injection, but it stopped the disease in its tracks. But it did require repeat dosing. And that was the first gene therapy for SMA, and it completely worked. Like just stopped the disease dead in its tracks. And then the even more kind of amazing thing was about 2 years later, and this is now maybe 2019. I'm losing track of dates here, but the gene replacement therapy for SMA became available, and it's given in the first month of life, ideally, and it seems to be providing a lifelong cure for a disease. And so a baby has the disease, they're diagnosed with newborn screening now here in Utah and across the nation. And if they get that gene therapy replacement, they are cured for life, and you could not tell them apart from any other kid walking around there in the playground. Just like a profound cure for a genetic disease, like first example in history where we've taken a disease that's crushed families and children and given them like a full life ahead of them.
And so, how is the therapy done?
So the therapy, the example for SMA, this is one flavor of gene therapy where you give back the missing gene. It's carried on a virus, but this virus is a virus that has been inactivated. So it's just a transport, a way of providing transport to get the gene back into the cells. And so the therapy is given as a single IV infusion, and that's it. You spend an hour getting the IV infusion, and then that's it. You've got the therapy. It starts working right away, and it's expensive, but it's delivered in a special crystal vial with a tracking number and a GPS device, so they don't lose it. And people are very careful that they don't drop it on the floor when they're about to give it through the IV. And then the kid goes home. They get the therapy like in the outpatient setting at the hospital, and they can go home.
And so, how is the gene targeted in the process? So, you give the IV, what's in the medication? How does it find what it's doing? And how does it make a generalized change in your body?
So depending on the type of gene therapy, you first of all need to make sure it goes to the right part of the body. And so SMA, as an example, it needs to go to the nerves that go from the spinal cord out to the body because that's where a lot of the problems happen in SMA. And so that's why it's given in the IV because then the virus floats around in the blood and can go to the nerve cells that go from the spinal cord out to the muscles. Other kinds of gene therapy, for example, there's a gene therapy for a condition called Alexander disease, which is a brain disease. That gene therapy has to be given in the spinal fluid because it needs to go directly into the brain. And so instead of doing a lumbar puncture, we do a lumbar puncture. Instead of pulling fluid out, we're actually pushing fluid in. So it goes up into the brain. So the different types of gene therapy are targeted to where they need to act and which type of cells they need to be reaching.
And does it have a generalized effect then? I mean, I think of a virus getting into certain kinds of cells and then replicating. So then this is able to replicate throughout the nervous system as a result.
In the virus form, the virus is made so it doesn't replicate, but it's given in such large numbers that it can still reach enough cells. One of the things we've learned about gene therapy is, of course, it works tremendously well and does amazing things, but it can also cause side effects that we need to pay attention to. And the role of the people giving the gene therapy, whether it's someone like Dr. Butterfield, who's one of our neuromuscular doctors, or myself with some of the brain diseases, is that we need to talk to the family and alert them for kinds of symptoms they would have that are specific to gene therapy. And so an example of that is that for some of the types of muscular dystrophies, the gene therapies work great for helping the muscles, but the heart is a muscle, and so we need to alert the family that if there's any issues with the heart or weakness, that they need to come back to the hospital. And so there's a whole new field of medicine as we deliver gene therapies that didn't exist before for how do we take care of kids after gene therapy treatment.
But as the replacement happens, then that's a permanent change.
That's a permanent change, and that's what's so amazing is that although one of the big points that are often thrown about in the press are the high costs of gene therapy, but the reality is that the treatment is a lifelong cure. So you're looking at a one-time treatment that persists for 80 years. And so that, as a benefit to the child, as a benefit to the family, as a benefit to society, is tremendous. And in contrast, we as a healthcare system spend lots of money on treatments with less efficacy and shorter timeframes of how effective they are.
It seems like they're both practical and philosophical issues at play there. I mean, from a practical point of view, the other part of it is if you can fix a neurologic disease, subtract then the cost of ongoing treatment over time, and it may be a bargain compared to a number of ICU admissions. But then the other issue, of course, is what is the value of a human life, both in terms of the quality of life and the quantity of life? And those are questions that I think deserve to be thought about very carefully by all of us.
That's a good point. This has not been something that I think we in pediatrics haven't had the opportunity to force not force, but to make the healthcare system as a whole realize the value of a child's life because adult internal medicine has had high cost treatments with relatively short benefits. So, for example, every year there's about 10,000 liver transplants in the US, each of which costs about $1 million, and the lifespan benefits about 5 years. And that's a high cost, high burden to the healthcare system and to society, but that's totally accepted by our society and by our healthcare system. But yet there's debate about delivering a curative gene therapy for a child with lifelong benefit. So it seems like our society has yet to grapple with this philosophical change in how we can treat disease in pediatrics.
So the treatment for SMA is a gene replacement therapy, right? What can
Right.
you tell me about gene editing? Can you give me a view of CRISPR that I can understand a little bit?
Gene editing is the exciting future that is not quite here, I guess would be the
Uh-huh.
best way to say it.
Yeah, but there's a lot of interest.
There's a lot of interest. The advantage of gene editing is that it's much more precise, potentially, and can reach diseases that are hard to do with gene replacement. Gene replacement works for diseases where a gene is missing or you're missing the copy you need, but gene editing can do any disease. So that's the real large benefit that we hope from it. The problem that we have with gene editing currently is that it's a molecular scissors that goes in and fixes the exact spot that's not working correctly in the gene. But those scissors sometimes go other places as well in the DNA.
Hmm.
That's the problem. If they go someplace that causes cancer or go someplace that causes your muscles not to work, that could cause some problems. And so that off-target effect has not been cleaned up enough yet for broad use. And so that's the challenge right now before CRISPR or other kinds of gene editing become really more standard.
So that's one thing that we'll anticipate for the future. What other sorts of developments do you see happening in the future of genetic therapies? And some of this, frankly, from what you mentioned last week, sometimes things just sort of drop in your lap that you say, oh, wait a minute, there is something we can do about that. And I'm sure there'll be more of those in the future.
Yeah, I think the other thing I'd like to point out is that now that we understand diagnosis so much better and get diagnosis so much faster, we have whole categories of disease we didn't know existed, which means there's kind of opportunities for treatment we didn't know existed. And so we've been really fortunate here at the University of Utah and Primary Children's Hospital to be involved in a treatment for a condition called vanishing white matter disease. It's a severe disease of the brain where the white matter is affected and causes and degenerates. And we didn't know this disease existed until we were able to do MRIs. And then more recently, we couldn't diagnose people very well until we had genome testing. And now we suddenly find that we have 10 or 20 patients around the state with this disease. And at the same time, in the basic science labs, people have been working on unknown to them, working on the very gene that causes this disease. And so there suddenly became in the past few years this kind of perfect confluence of realizing the extent of this disease in people and realizing that we knew what the gene was and how to treat it. And so new drugs were developed that are now being tested to see if they can cure patients. And so I think more and more we'll have kind of these unexpected coincidences of science in the lab meeting patients and families where we realize the extent of disease. I think that process will happen more faster.
Other things you see, other promising developments on the horizon?
I think the other thing is the challenge isn't so much the technical aspect, but the ability for us to deliver on our promise to do it. So for most genetic diseases now, we understand how to make a treatment and to deliver it, but the cost is high of both money and time, and that's what's holding us back from doing this faster and better. And that's a decision at the level of society, at the level of government, about how fast, how much investment we want to do. I think that's where it's moving outside of the realm of what we as physicians and scientists can do, and really relying upon ourselves as a society to say, yes, we should put the time and effort into doing this correctly.
Anything else worry you about the future?
I think I feel a lot of hope on the one hand, because I'm just so happy that we can use genome testing to make a diagnosis. I'm so happy that we have treatments available. I walk into the hospital or into the lab and like I'm excited about the work I'm doing each day. But then I've also faced struggles where we have a treatment, we know the path to do a treatment, and yet the funding to make it happen is held up by squabbling inside the government or someplace about what are we going to do with that money? Is this the right way to spend it? And so I feel great hope and optimism, but also it's not something where we can be passive about advocating for the good changes to happen.
Yeah, I think very well said. That the thing that we can't ever lose sight of is that innovation is expensive both in times of money and time. But this is the kind of innovation that has practical implications that can be history changing in all the best ways.
Yeah, I think one of the examples I use in my book is that CRISPR, the gene editing technology we were just talking about, grew out of very basic science work on some scientists studying bacteria. And so if you said that in front of a lawmaker that you're studying bacteria, they would just laugh you out of the room. But in fact, that is the promise of the future of genetic medicine that's going to be important for millions of people. And so that's the kind of investment we have to care about.
That's what we have to care about. Well, Josh, thanks so much for your time and expertise, for educating us over the last couple of weeks. Thanks for writing a very interesting, empathetic, and intriguing book. I'd recommend that it's available at all fine booksellers. Support your local bookseller. And it's been a real pleasure talking to you.
Paul, great to be here today. I really enjoy our conversations.
I hope we don't wait another 5 years before we talk again.
Exactly.
All right. For our listeners, please send your questions to questions@vcurb.com. We'll deal with those next week. Thank you so much for your support. Thanks for listening. Thanks for recommending us. Thanks to Elisa Stoddard, who makes this sound like a podcast. And thanks, Janice, for listening. We'll talk to you all next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.